them to spend their time. So, Nick, why don't you give us a sense about what's going on in your world and what you think about the next 3 years?
Well, I think it's pretty interesting to follow the governor and the way he lays out his vision, and I'm very appreciative of the opportunity he has given me moving forward. We talked quite a bit about the river of opportunity, and he talked how this is his second real stab at the river. The first one being the organization of talent and economic development programs within the organization he did earlier. The second piece, of course, is really looking at the services provided both in the human services area and the health services area. And when we started examining this, and I was the people group lead, we really started to see that there was a great overlap in much of the population that we served. And we have some initiatives coming. A few will come up possibly in the questions, I'm sure in Linda's questions, if you don't have any. So I welcome all of you to ask as many questions as you possibly can. But certainly, the State Innovation Model Grant and what we're trying to do towards community health innovation regions and encouraging accountable systems of care, both community-based level and through what we're doing with our managed care rebate is something that is very important to us. And we saw an overlap there with the 11,000 people we have in the Department of Health and Human Services today that was formerly the Department of Human Services in our county offices. 11,000 people on the ground who really see the people, see their problems, and really should be part of the solution, both as it comes to either issues around family or children, or even around issues as it relates to behavioral health and physical health care itself. So the new department will be effective April 10th, and I'm looking forward to it. Much of my work up to date has been working on the internal organization and working through some of the issues there, and really looking at some of the federal programs and the roles and the opportunities that may present itself in the future moving forward. So for those of you who've spoken on this, I thank you for your support moving forward. The second thing that we have going on is the managed care rebid and the State Innovation Model Grant. I'm going to kind of use those two in the same breath because they're really about trying to transform the system of care from one that's payments-based, volume-based, to one that's quality-based and one that's quality-based rather than volume-based. And that's, for those of you who've been in health policy for years and years and years, that's something that we've really been driving and pushing for, maybe for a generation, since my introduction to health policy, some 15 years ago. And what I would say is, it's very easy to say. It's very difficult to do. And the rubber is starting to hit the road with where we're going. And this is a great time, and it's a great opportunity for us moving forward. And then, thirdly, I can't let this go by without mentioning it, but as of yesterday, we had 603,000 people on the Healthy Michigan Plan. Yes, tomorrow marks 1 year. Very excited about this. The governor went through some of the statistics, so I won't repeat them. What I would say is there's been hundreds of thousands of behavioral health visits as well. So as we push towards integration of care, as we push towards really looking at the whole person, obviously a very important concept of this is integrating physical and behavioral health. So with that, that's my introductory comments. Thank you, Linda.
Chris, tell us a little bit about the priorities that you're helping to move.
So obviously, Nick and I work closely on a lot of different things, whether it's the rebid, the River of Opportunity effort, which is really one of our largest focus right now, and obviously Healthy Michigan and its continued success into the future and on a going forward basis. The governor mentioned we still have we have a second waiver we're about to pursue that we have to have signed off for by the end of this year in order to keep Healthy Michigan to continue. So there are a lot of efforts going on. But one thing I'll say is that Nick and I were at a conference with the National Governors Association. Most of the healthcare advisors get together. Most of the governors' healthcare advisors get together once a year, and we're listening. It's two folks from each state, and we're sitting around listening to folks. What are you working on? Well, I'm beginning to think about preparing a state innovation model grant. Well, and then you go to another state. Well, we're thinking about how to really bring together physical and mental health. Then another state would really think about, well, we're talking about opioid abuse and prescription drug abuse really is an issue we're thinking of. And we go around the table, and Nick and I were just looking at each other going, oh my God, we're working on everything. Like that's everything that we're working on right now. Every state's really kind of taking on one at a time. And as we've implemented things, whether it's the state innovation model, whether it's the River of Opportunity really has gotten a lot of attention, we're continuing to get calls from state after state asking us about, how are you doing this? How are you really, what are you trying to achieve? And looking to us as models. And I think that's a great testament to Michigan, that we're now seen as a national leader in healthcare, and that people are looking to us to kind of set the way forward. And I think the governor talked a little bit about how we can influence that national dialogue, but we're doing it through action. And we're doing it through, by being pragmatic and thinking through, how do we really get at the root causes, not the symptoms of all these problems. So from my perspective, I'm really proud of where we're going, but we have a lot to do. We have a long way to go. And I think one of the things that we're looking to continue over the next few years is how do we set ourselves up for the future, and how do we continue to be that national leader through there. So whether it's through continuation of Healthy Michigan, whether it's through a state innovation model, whether it's through our rebid, using the tools at our disposal to continue to making Michigan that national leader and that shining light. So that's something I think I'm personally very excited about.
Very exciting. So Nick, you've been on the job for what, 3-4 months before you became
Which job?
the first job that you took,
You've gone through a couple.
Yeah.
right? Before you became the director of the largest department in the state. Talk to me a little bit about culture, because we all understand how important culture is to affecting the kind of change that you want to make there.
Well, I think a couple of things is certainly there's a significant difference in the way that the Department of Human Services and the Department of Community Health provided services. I spent more than a decade within the Department of Community Health, and we are very focused on our relationship with contractors. We have managed care health plans. We have prepaid inpatient health plans. We have public health departments. These are entities many times derived out of local power. Many times we contract with them through a bid process. So we really have a focus where we're dealing with an entity that's providing the services. We're human services. They have staff who's really on the front end dealing with people every single day. And I think that really brings about, number one, it's a lot more people. It's 11,000 people within the Department of Human Services and about 3,000 people within the Department of Community Health, so about 14,000 people total. I also walked into the Department of Human Services position at a time when we were facing staffing reductions as a result of the budget that was enacted last fall. So from a cultural perspective, there was not the greatest positive energy around where we were looking at some of the cuts and the reductions. And I think moving forward, what I've really tried to do is empower the leadership in both places to say, this is where we're going, this is the direction that we're driving, and really make sure that they understand that they're trusted in the jobs that they do. And that will go a long ways, I think, towards bringing about some positive, effective change in the Department of Human Services, and really even help us as we look at where there's commonality. Just 2 weeks ago, we brought together the 300 top-level staff from the different departments. And I'm not sure what was really expected, but it was in a room like this, and the most valuable part was seeing the people talk to each other about what they were seeing on a day-to-day basis. What sort of interaction could there be between a behavioral health entity in the community and the local office? And we didn't talk about too much on this, but the concepts of the river are built upon successes of the past. And we talk about pathways to potential and putting success coaches who can do human services work in schools directly. It's like it serves the whole person. For the past several years, we've been trying to put children and adolescent health centers in the same place and working with many of the hospitals to provide services in schools. We talk about behavioral health issues with children who are in foster care, and yet we have really ensured that Medicaid coverage is now available, and a waiver that we have for children with serious emotional disturbances is being provided to individuals there. And then on the employment side, and moving people away from a pattern of dependence and more towards self-sufficiency, it's really about what can we do to ensure that there's a smooth handoff to the workforce agencies in these states. So when people are prepared to get a job, they can work with the employers, they can work with our Michigan Works agencies, they can work with the many people who are looking to hire and really get the opportunity they need. And the governor talked about this, but our metric really needs to be outcome-based and not output-based. And that's something that is cultural in a way as well. And this afternoon, I know you'll be talking about some workforce issues and employee engagement and what we can do to empower staff and what we can do to improve the patient relationship and things of that nature. And what I would say is if you could move towards something that's outcome-based rather than output-based, and if you have individuals who are looking at how can I improve your life today, not what is my metric for the success that my boss wants tomorrow, you have a much more engaged and a much more successful workforce. So that's how we're trying to push forward on that.
Great. So Chris, talk a little bit. The governor talked a bit about having the right sorts of metrics in place. Talk a bit about the kinds of metrics he's looking at for this new kind of merged department and what it means for healthcare.
I actually might let Nick handle that because we're honest. And here's and I'm not trying to dodge.
You guys
No,
decide.
He's dodging.
Literally, they've been working on this lately more in depth than I have. So that's why it's right now we're working through all those issues. Right now, it's trying to get the organization set forth, and at the same time develop some of those metrics. So things, Nick, I'll let you handle what you've been looking at.
I think overarching, if you're looking at the person and how we drive them towards success, and the metrics really have to be, is a child able to learn in an educational environment, and is an individual able to work towards self-sufficiency in the employment environment, and there's those are overarching outcomes I think are very important, and of course there's some proxy metrics we have in there. A few of them, excuse me. A few of them that we've looked at is truancy in the schools, and certainly through pathways we've decreased truancy significantly, and that means children are in an environment where they can learn. And in some instances, in many places across the state, they're in an environment that's safer for them. Increasing workforce requirements around the food assistance, the family independence program, and some cash assistance payments is very important. We talked quite a bit about personal responsibility on the health side and what we're doing in Healthy Michigan Plan. But it's very important to note that what we can do to help people become more employable in the future is a very important part of those programs as well. And I think in any of these metrics, it's really important, and we need to improve upon this. We do a good job measuring why somebody comes onto a program. Do they not have enough money? Do they have a problem at home? Do they have whatever it may be? Transportation issues is good. Yep. We don't do a very good job saying, okay, 2 years from now, where did that person end up? Are they successful? Are they working? And that's something that we need to move towards as well.
So let's talk about the Healthy Michigan program. You all have touched on it a bit. The governor talked a bit about the successes we're seeing and the vast number of people that are being covered. But I think you have a couple obstacles that you have to overcome in the coming months with CMS on the second waiver. Talk to us a little bit about the second waiver, how you think you'll work your way through that, and what we as healthcare leaders can do to help sure that these people continue to have access to coverage.
So we began talking to HHS about this last year. Late last year. I want to say November, December timeframe is when we first sat down and started raising this as an issue. Really starting the dialogue, and it's continued as late as last week. We've been having pretty regular conversations with CMS. For those of you who don't know, Healthy Michigan requires that we secure a second waiver. It has to be submitted by the
state
September.
law.
The state law.
The state law
requires it. That we have to submit a waiver by September of this year and secure approval by December. And the idea is it has to contain a few elements. First is after 48 months, you have to give individuals the choice to either go to the exchange and access tax credits for coverage, or stay on Healthy Michigan and have increased cost sharing. So the cost sharing issue in particular, I think, has been is one of the larger challenges. That's not a uniquely Michigan thing. This is a consistent issue that states have had with CMS throughout the process. I will say one of the other challenges that we faced is a lot of the folks in CMS have turned over. So the people that we were talking about with Healthy Michigan when we first implemented the law have now left. So Marilyn Tavener's gone, Cindy Mann have gone. And so you really have a lot of acting staff at CMS. So you're kind of starting from scratch with staff. There's not the institutional knowledge of who we worked with originally is gone. So that in and of itself is a barrier and a challenge for us to overcome. But we've been working on it, and I think we've made good progress so far. Between the cost sharing issue is something that every state has faced, but there's a path. There's a path forward on this. It's just it's going to take a lot of work and a lot of discussions with the federal government. I'm cautiously optimistic. I think that we have had a good relationship with CMS and the federal government on this to date. They've seen a lot of our resorts. We've been sending them our metrics when we get them for Healthy Michigan, so they hear things like There have been 450,000 primary and preventive care visits. There have been 48,000 people served by, have had access to mental health services. And they hear that, and to them, that makes a big difference. And then our enrollment numbers speak for themselves. So they feel positive about the direction we've headed. But this is just another issue, another thing that we have to get through.
Quite frankly, Michigan was leader on this. So I think CMS recognized that in a lot of ways, and other states used. I mean, Chris talked a little bit about the event we were at in Washington, D.C., and he's right. We were actually on our phones and texting it. Every time a state would bring something up, we'd have that one too. It was, you know, mental health and wellness recommendations, substance abuse, and so many of those things. But so we've been proactive. We've been working with CMS. We came up with something that worked. Was approvable in its first form, and many other states really latched onto that example and used it as a model going forward. Now, they in some instances have pushed CMS maybe a little bit beyond where we were able to push them, and that's something we'll have to talk about. But I think it's important to remember that when we first threw out the Medicaid expansion as an idea, our first piece was really, it was about moving general fund dollars that were spent on community mental health, state taxpayer, state-funded dollars. And this gets lost in the conversation and needs to be remembered, I think. And saving half the money from that and setting it aside to pay for the federal match for years and years and years to come. And as we moved through the budget process, and as it happens, other priorities came into play, and that money was then utilized for other programs. And so we've got that ahead of us too at the state level, where we have to really move, really make sure that people recognize that, and that for us to go back and look at what it was pre-Healthy Michigan Plan, it would take a significant general fund investment to put community mental health where it was before the act, before the law was enacted.
So the governor talked a little bit about the stats around it. And I think we're all fairly surprised and in awe of the fact that there are 600,000+ people in this plan. Your original projections of it were, I think,
about 500,000.
About 500,000.
I mean, our initial one-year projection was about 320,000 for year one.
Right.
The universe that most everybody had, no matter what data source you were looking at, was about 500,000. And so the fact that we're above that actually is really surprising.
Yeah. So what are you learning about these people? How are they approaching healthcare? What are their needs? And how is that going to kind of shape your thinking around the rebid?
Yeah.
Well, I can tell you what we've learned is they're very engaged and proactive in wanting to improve their own health status. I think that's a very important to remember and note. When doing the health risk assessment, a vast majority have chosen to take it, and as we worked through the legislation last year, and there's a carrot. We can reduce cost sharing if somebody takes the steps towards improving their health in the future. And so while the cost sharing is limited by the federal rules, we're able to reduce it if they take some actions. And we found that really people approached some of the most intractable health behaviors to go after, specifically smoking and obesity and physical fitness, which of course are some of the most significant cost drivers we have. We haven't talked about that too much this morning, but there's certainly preventable things that we all can do. Every single one of us will reduce the healthcare costs, the healthcare cost burden on government and businesses, and we've seen that engagement. And I think that's been not very educational for all of us, and really shows the opportunity that if you give people the opportunity to really do something to help themselves, they'll take advantage of it. Yeah. Anything you want to add there?
Yeah, I'd say that there's a lot of pent-up demand for services with these folks. I mean, and we recognized that when we were doing our rate setting for the health plans as part of Healthy Michigan. We did rate it somewhere between kind of our age-blind and disabled population and our typically our temporary assistance for needy families population, because we knew there was a lot of pent-up demand. And you hear. And we're continuing to get data back on kind of what those conditions look like, but then you hear anecdotal stuff like I think Ascension Health Plan was at a conference last week at the University of Michigan, or Ascension Health System was there, and they said that one of the things they're seeing is predominant in the Healthy Michigan population is something like cellulitis, or some unique conditions that really haven't been as predominant in other Medicaid-related populations. And so we know there's this unique need and this unique pent-up demand that we've seen. And surprise, surprise, they've been using those services. The great news is that we've seen so many primary care and preventive visits, but they're still using those services. I think it's going to be an evolution for folks to continue to say, how now that they have coverage, how do they use it? And keeping that kind of focus on in the primary care medical home and other preventive measures and wellness measures to keep it, wow.
You've astounded everybody.
Moonlighting? I don't know.
Maybe this is the part where we dance.
I don't think so.
No?
I don't know.
I vote for Nick to start it out. There we go.
All right. No dancing today.
So yeah, I mean, surprised these folks have had coverage. A lot of folks haven't had coverage before, and they're using it. So I think a lot of folks. But the good news is that there has been access. So I think that some people predicted that there would be, there's so many more people in the system, we're going to have huge access problems. I don't think we've seen evidence of that to date. I think we've seen that the system, whether it's health systems or physician offices, have been able to accept those folks, and that's overall has been a positive for the rest of Michigan.
And Chris talked a little bit about pent-up demand for services. We had an uninsured population that was more than 1 million people, so there was this presumption about what the take-up rate would be, and the demand for coverage itself was higher than what might have been anticipated based upon prior experience with the Medicaid program. And it really showed the demand and the importance that people felt about healthcare coverage and them assessing their own risk at what a healthcare emergency or some significant healthcare event might mean to them personally or financially. So it's a very positive story that came out of this.
So there's still a big portion of the population that remains uninsured. What are you doing to help them get access to this coverage?
Two things. I think that certainly moves over into the exchange part of the conversation as well. So if you look at both numbers combined, we're approaching 1 million people who are covered by both the exchange and the Medicaid piece itself, the Healthy Michigan Plan. So we're continuing to work with our partners and assess where there may be potential gaps in the population, and that's what we're going to continue to do. We believe that healthcare coverage is a positive thing. With that comes a responsibility, not just in behaviors, but also, and this isn't unique to the Medicaid population, we've all had to move in this direction a little bit, and I have some anecdotal stories I could tell you about myself, but it's about better utilization of the healthcare card as a whole. It's about really getting into the primary care physician, getting your preventive visits, getting to the physician before a problem exacerbates into a hospital visit or an ER visit, and this is all chronic diseases and the prevention of diabetes. It's getting ahead of it with behaviors is very important, but with this population, I think there's been a dependence on sort of the 24-hour availability of ER care, and we need to really move them towards primary care. And then what can we do? And we have programs that the Michigan Primary Care Transformation Grant, for example, that encourages after-hours access. I think Mr. McClellan talking about, and this is something that drives me crazy, talking about when you call the after-hours phone, if there's an emergency, call 911. How can we better case manage or care manage in that circumstance so that we are utilizing healthcare in a more effective way? Because if we really want to keep that cost flat in the future, we really want to bend that healthcare curve, then that's something that we have to more aggressively pursue.
And I also think it goes back to what the governor was talking about with the river of opportunity. I mean, this isn't just about state government doing things, the federal government doing things. It's also about partnerships in the communities. And there are places and communities around the state that have stepped up and really offered support for those who may not have access through various eligibility criteria or whatever. But that's kind of gets to what the river is all about. Not just us reorganizing and realigning ourselves, but also partnering with community partners to say, how do we treat you like a person and figure out, okay, how do we provide you the support that you need? So that's kind of one of our missions going forward.
So let's talk a bit about the rebid. And I know that you're fairly limited in what you can say and how you can say it, but you do have some underlying principles about how you want to reshape the Medicaid program going forward, and I think you're going to use the rebid to help you deliver that. I've heard a lot of conversation today around primary PCMH and using PCMH or a medical home is a more viable way to deliver better quality and outcomes. How is that going to work within a rebid process?
You go first.
So the principles we've laid out for the rebid are, and we have to be careful about what we talk about, obviously, is population health management, value-focused payments, so going to the ACO question that was asked earlier, integration of care, although not necessarily ACOs, but value-based payments, integration of care, and structural transformation. Those are some of the principles that we've laid out for how we are approaching the rebid and the way we envision moving the system forward using that lever. So how that comes about, I think the details of which are TBD, and I think we have to be careful about how we talk about it.
You can share your secrets with us.
I appreciate it. It's just us in the room, right? But that being said, I mean, I don't think this is not going to look like the previous rebids that we've done. This is a very large portion of Michigan. I mean, the Medicaid MCOs cover about $7 billion. Is that right?
Closer to 8.
Yeah, closer to 8 now. So about $8 billion of spending of healthcare spending throughout the state. So it's a pretty significant influence in kind of what the system can look like, and we envision being proactive with it. So this will be a little bit different than we've seen in the past.
And certainly, I think we have a strong tradition of managed care, and we're going to build upon that. And I think that they've helped us, be more efficient and save dollars in the past. And when you look at that healthcare cost curve, and you think about what the burden of the Medicaid program itself has been on the state general fund, it's almost zero over the past 10 years. There's a couple of different factors for that. One is our ability to utilize some Medicaid financing, especially as around provider taxes. Some of it is related to the general fund match rate, but much of it is really, I think it's very important to note that we really have kept that flat for the state taxpayers for a long, long time.
Yeah. The other thing I'll mention, it was the governor mentioned earlier about the Regional Prosperity Initiative and really how we're trying to, as part of the River of Opportunity, really collaborate at the local level. Well, one of the things that is going to be different this time around is that the regions for which health plans can bid bid in are actually going to be divvied up by prosperity region. So you'll have 10 regions, and before we had 17, I want to say, but I can't remember right up. 13?
There are a lot.
Somewhere around there. But so the idea is to encourage that kind of collaboration and stuff within those regions and continue to have those resources, in those designated areas. So that will be another thing that we will focus on as part of this.
Great. So how do you think about what you've learned with the Healthy Michigan plan and applying it to kind of the future of Medicaid? So you did a lot of innovation, and I know you have some limitations about how you can innovate the broader Medicaid program. What are your thoughts about that?
I don't know if I can say a whole lot. I mean, certainly there's pieces around the Healthy Michigan plan that we'll utilize in the bid itself, and there's other parts that will be unique to the Healthy Michigan plan because it was defined in the statute. I think really it'll be a lot of the concepts that are in our state innovation model grant that we're looking at as well, and around health information technology and health information exchange. How can we push everyone forward in a direction that makes the system more effective, more transparent, will be what you see in the bid.
So let's talk about the SIM. It is a pretty big, audacious goal. I think it's going to be a lot of work to make sure that you can get the community and the providers and the payers to all collaborate around it. Talk to folks about what you're hoping to get accomplished with it.
I think that, well, first, let's be clear. So we were, for those of you who don't know, we were chosen as one of the states to test a new model that was developed in collaboration with many of the folks in this room, community leaders, business leaders, health systems, et cetera, to really begin focusing on paying for value over volume and having a more value-based system and really aiming to improve the population health of our state. So this model, which right now we are at its infancy, so we were just awarded $70 million by the federal government to help implement it and to use that for infrastructure, technical assistance, and to begin testing it throughout the state. So our overall goal is to improve the health of Michiganders and to begin getting more value for our healthcare dollar. And we believe we have a model that it's going to be a lot of work. It's going to require payers. It's going to require Blue Cross. It's going to require Medicaid, a variety of multi-payers to help bring our funds together and say, okay, how are we going to incent focusing on value over volume? And we're going to test it in a few areas around the state. We have not chosen what those areas are yet. We're still working through that. We're still analyzing what if people have the ability and the infrastructure to meet the model as we've laid it out. And we think there are areas that are really excited about trying to be test ground for that, and there are places throughout the state that really want to push and be on the forefront of this. So it is going to be an evolutionary process, but we're just getting started. And I don't think we're under any illusion that's going to be easy, but that's not what we're about. We're about trying to get to the hard solutions and trying to get to the outcomes, not the outputs.
And a real important outcome in this too, it's addressing the determinants of health. It was asked over here somewhere about what are you trying to do to address the determinants, and there's really two approaches that I think, or two different tactics you could look at in this, and one is the front lines of the human services worker, and obviously that's part of the conversation behind what the river is all about. But within the state innovation model design, it's something called community health innovation regions, and this is really about what are we doing at the community level, what partnerships are there, how are the hospitals working with the local public health departments, working with the local business leaders to say, here are the problems in our area, and this is what we're going to do to address them. And the community health innovation region will be a very important aspect, a very important driver of really getting at what the determinants are, in an area.
So we started talking a bit about value-based care and how you want to change kind of the reimbursement formulas and what we have to do kind of as a system. And I think we also understand that there's an infrastructure that has to support that. Yeah. So I know that you're doing a lot through MyHIN. You've got the HIT Commission. Talk a little bit about what you're trying to build there so that that data can be shared amongst providers and payers and facilities in a way that allows us to get to better outcomes.
Well, I think the movement of information is going to be very important, and the federal government made a significant investment through electronic medical records so that we could all interface with each other and be able to share data in a more effective way. There has to be a backbone and a central support piece that really supports that, and we have our health information exchanges that are out there. The coalescing entity that is for the purpose of helping the exchanges talk to each other is the Michigan Health Information Network. They establish the standards and the protocols and the methodology for which data can be shared, and that's going to be a very important backbone of this, as will the other exchanges that are out there. Today, I think a lot of this we're at the infancy at. Or maybe not, because those entities actually grew out of the old regional health information entities, and they were able to share locally in some aspect. That was their goal. But really now, how do we move this data across the entire system? And as they're allowed to go statewide, as you can imagine, we saw different models that were successful. The Upper Peninsula was able to communicate very effectively with behavioral health, for example. Some of the exchanges have a strong network with physicians and providers. Some have a more better connection with hospitals. So you have to be able to work all of this together in a way where we can effectively move and utilize data. The first piece of this is admit, discharge, and transfer data. Certainly the payers, certainly anybody who's looking at care or case management has to know where their person is or if they've left the hospital. And it's pretty interesting because what we've seen on the physical health side with the electronic medical records, we've seen some variation between systems, some difficulty interfacing. I'll tell you that sometimes we sell IT as the solution, and many times there's a lot of work that has to go behind the scenes or increase processes, and that can mitigate some of the efficiencies to be found. Where we've really seen some success is on the behavioral health side, and they've come together partially out of necessity because there wasn't a lot of federal money available. They've come together and started looking at this information, and they're very excited about what they might be able to do and very excited about being able to coordinate physical and behavioral health. So that will be very important moving forward.
Chris, talk a little bit about the practical outcomes for the business leaders in this room of having that kind of an infrastructure.
In terms of having the IT infrastructure,
Yeah.
I mean, practically,
What
the idea
do they
is,
get for it?
What do they get for it? I mean, theoretically, you should see reduced costs in your healthcare dollar. Mm-hmm. Now, that's going to take some time because you still have to have the infrastructure in place. You have to begin to transmit that data all across payers. But hopefully, and this is the concept, is that hopefully over time, you will see more coordinated care and better value for your healthcare dollar as a direct result of that investment. And for business leaders, that should be something that is encouraged and advocated for, in my opinion. So the work that we've done around MyHIN we've made a lot of progress. We still have a lot of work to do, but there's tremendous potential there. And the fact that we've made this investment, I think, is something that for the business community, they should begin to see, hopefully in short order, an ROI on.
Great. So we haven't talked about King Burwell yet, and I know that there's a lot of buzz right now about what's going to happen and what the impact will be on Michigan. And I think, Nick, you talked about the fact between the Healthy Michigan Plan and the health insurance marketplace, we now have nearly 1 million people that are insured today, that if King Burwell were to be decided in a way that that $900 million of federal subsidy can't be pulled down for those 300 or 400,000 people that get it today, it puts you all in a really interesting position. So talk to us a little bit about how you're thinking about planning for contingencies.
You want me to do it? Paper rock,
Yep.
paper rock, scissors.
Yeah. You
so-
go first on this one. I
All right.
was trading back and forth, but I think I'll let you go.
Okay. So, well, first, we don't know what the
right.
what the decision is going to be until the decision comes down. I mean, not a lot of folks expected out of the last court decision that Medicaid, an expansion of Medicaid would be an option to the states. I don't think anyone really predicted that outcome. Well, not a lot of folks did.
I did not. I will
You
admit
did
that.
not.
No, I did not.
But that being, so we have to wait for what the decision is to know how to address it. So it's not like we're going to come out and tell you, oh, well, we're going to do X, Y, and Z, because we don't know what's actually going to happen. They may rule in favor of the government, and if that's the case, then a lot of this, a lot of the issues that could come out of this case don't happen. Now, what could happen is if those folks have subsidies. Today, the average monthly premium in Michigan is about $366, I think. And so with after subsidy, that premium goes down to about $130. So there's a pretty big gap there. And if the subsidies through the federal exchange aren't allowable, then obviously those folks who are receiving subsidies will not receive subsidies, and they will go back to that higher rate. And if that occurs, then I think there are several challenges that we could have. It all depends on how, right? Mm-hmm. Again, this is in the event that they rule for the plaintiffs, which is not a foregone conclusion at all. So, but if they did, then you have a few issues that could happen. You could see rates in the individual market go up significantly. As those costs go up, people would drop out of coverage. And if that's the case, then people who would stay would most likely be sicker, as they need the health care, they need the access to coverage. So if they are sicker, then you'd see rates increase. And if you saw rates increase, then you'd have more people drop, and then you rinse and repeat. So that's a challenge. The other issue is that Medicaid could actually see some higher caseload, and that could have an impact on the state budget, especially those who today the exchange may be preventing them from spending down assets to go on to Medicaid. So if they're not able to access the exchange, some folks may spend down resources and come onto Medicaid. And if that's the case, then those folks are at the current state matching rate, which is about
36%.
Is that right?
34%.
34%. And so there could be a state budget impact there as well. In addition to that, if you have less people in the individual market and less people covered, you'll also see our health insurance claims assessment revenues decline. But how that happens?
And you'll see uncompensated care.
And uncompensated care will increase,
the
which will put
pressure
more
on the hospitals especially.
Right, at a time when they're seeing Medicare changes in financing. Yeah. So it's a complicated question. We are beginning to think through various scenarios and how that might play out. But in all honesty, we're not really going to know until the court comes down. And at that point, we'll assess and say, what do we view as the plan for Michigan, move forward. We've always said, the law is the law. If it changes, we'll change with it. And so that's it continues to be our philosophy.
Yeah, and I think, we don't know what we don't know, but Representative Upton, who's from Michigan, is part of a group that's looking at I'm going to call it a glide path, but potential time frame where if they do find against the government on this, then we're always looking for opportunities. And the one thing about this administration, and the governor talks about this, we talk about relentless positive action. We are going to assess the situation as it exists, and we're going to move forward in the best possible way for the citizens and the businesses of the state of Michigan.
So if you're going to wager on this, how would you wager? What's the Supreme Court going to do in your mind?
I honestly have no earthly clue.
Yeah.
I mean, I listened to the arguments, and I mean, I think it could go either way. The way that they called the case was a little unique, but I think that some of the things the justices said were, tended to lean towards the government. I mean, you really have no idea. I really couldn't even put a wager on it.
I avoid all legal law-related reality TV shows, so I wouldn't even know how to assess what the chances are. What I've seen is as close to 50-50 as could be, and what I think is interesting is all the pundits and the analysis that think they really read something from what the questions were, and I think it's interesting that from the silence or from the questions a specific justice is asking that they're formulating an opinion. So it'll be interesting to see how it all plays out. But again, we'll assess it and we'll figure it out, and we'll move forward in a positive way, both with our federal representatives and our state legislature.
Yeah, and we have challenges we're working on right now. I mean, so we're focused on continuing Healthy Michigan. We have the second waiver we have to work through. We're in the middle of establishing a new entity to refocus on how we approach programs and how we approach serving our customers. We got a lot on our plate, and so while this is a contingency plan where we're thinking through and what might happen and what might be, we'll address it when it comes to that. But right now, it's we're working through a whole bunch of things.
So let's take the last few minutes that we have to talk about drivers of healthcare costs. I mean, the governor's touched on it. Certainly, Mark McClellan spent a lot of time talking about it as well. You all are very involved in thinking about how to make Michigan healthier and how to move those stats, because we don't tend to stack up particularly well on some of those key indicators like smoking or obesity.
Yeah.
Smoking, we've seen a decrease over the past several years, and especially children. Now, that part of it might be educational based, part of it might be tax based. I think anytime you can use a tax policy to drive better behavior, especially as it relates to keeping kids away from tobacco, that's a good idea. Infant mortality, we've seen decreased rates there. Teen pregnancy prevention, we've seen decreased rates there. I think anytime you're dealing with limited resources, and we have been for a long time, it's always a very tough decision to make between whether you're going to invest in something that will save dollars in the future versus are you going to treat the acute presenting chronic condition today. So otherwise, especially when there's an enhanced federal match rate or federal match for treating the condition today. So am I going to treat the person who's in the emergency room for a diabetes-related problem that's going to cost me thousands and thousands of dollars, or am I going to put a few dollars into a program that really tries to move the needle towards increasing physical activity and increases healthy eating behaviors? So that's really a tough task, and I think we're at a time where I think it's I don't know if it's revolutionary, but there's a significant attitude change that's come about in the last decade. Talking about ROI is much more accepted. Talking about evidence-based practices that reduce incidences of chronic disease is much more accepted than it was even just 10 years ago. And we're all becoming much more educated about our own health. I don't know, how many of you have these little devices, right? And I'm not asking but a whole bunch of us have them, right? So I can tell you to the second how many steps I've taken today. If you would have told me 2 years ago that I would have wore one of these things, I would have told you no way. And not only would I have told you no way, I would have said it wouldn't impact my behavior. This impacts my behavior like it's incredible. And we're going to see the continuation through mobile technology, through our own personal engagement. I think that's where we could really start to move the needle forward. And it is. We're always going to have an issue with resources, and it's going to be a challenge. But I think we're at the cusp of something that could really drive us in the right direction.
Right.
So how many days of the week do you get more steps in than the governor?
I do not know because I do not put myself on any sort of public site that anybody can
I have
track.
personally challenged him, and he has yet to accept it. So I want to put that on the record.
And he is accurate. I cannot deny his assertion.
So Mark McClellan talked a bit about the rise of specialty drugs. We all understand that it's about 1% of the prescriptions of the year, but it accounts for 30% of the spend. So it's a
She's saying 5 minutes. We're going to open it up for
I
questions.
thought
at
we
some
had
point.
till 11 o'clock. We'll move. Let's move to the audience. We'll skip that question. We'll move to the audience.
What I would say is the specialty drugs isn't unique to that. What's unique about that is the number of people that could be impacted. We've had specialty drugs in areas like children, pediatric cancers for years. What's the huge potential cost on state budgets is what's unique about that. And you know, I think we'll go through policies that help make sure we're using it in the most effective way moving forward.
Yeah.
Anything you want to hit on that? Good.
So let's take, I'm sorry, the last few minutes for questions from the audience.
Thank you for your comments. This is Brett First, CEO of Arbormetrics. I have a question back to the state Medicaid ACO. We even add into the MCO contracting and looking at the other state Medicaid ACOs that are across the country, there's only a few that were kind of like got the mix of MCOs like we have. Is there anything unique that you're going to be looking for and how you incentivize and share savings or other ways with that's going to give that alignment so we don't lose that valuable resource in MCO topology that we have here?
So let me be clear about something. When I was talking about that, I was referring to kind of our principle of value-based payments, and that's something that ACOs have really tried to accomplish. That's some of the underlying principle in ACO. I wasn't saying that we're going to go to a Medicaid ACO, so let me make that clear. But the focus on value-based payments, whether it's through our state innovation model, whether it's through the rebid of the Medicaid contract, is something that's going to be a little different from the way we've done things in the past. And I can't get into specifics for some. I think some legal reasons, but it is, our overarching goal will be to see that we are moving towards a system that encourages value, not volume.
Thank you for participating today. I'm Marilyn Bell with the Michigan Purchasers Health Alliance, and studies have shown that there is a real relationship between mental health problems, depression, stress, anxiety, and leading to physical and medical conditions. Can you expand further on what your thoughts are in this area of bringing these two together?
We have a duals proposal that the governor referenced earlier, and a care bridge that was really about linking behavioral health and physical health data. We have a strong, proud tradition of public mental health services in the state, and they are a local provider, and certainly the utilization of them is important moving forward. But that said, we have to make sure that we can share the data back and forth, and really there's pieces of the Affordable Care Act that talk about health homes. And we recognize, especially people with, chronic or severe or persistent behavioral health problems, they may be more comfortable utilizing a mental health provider as their health home. So those are all things that we're looking at. There's components of it built into our future strategies, but it's pretty complicated when you think about the state statutes and the different providers, and it's something that we're going to continue to look at. And with that, I also want to recognize Tom Watkins. We have a former mental health director who's here. Tom Watkins is here today, and also my former boss and community health director, Jana Olszewski, is here as well. And you talk about strong leadership and where we're trying to move in a positive way. These are a couple of people that have really driven that, both in their past roles and currently today.
Yeah.
So I think we had another question up here.
Just holler at.
My name is Teresa Dreyer, and I work with the Center for Healthcare Research and Transformation. You've both mentioned that the state is focusing on substance use issues. Could you speak a little more about what the state is doing and how it's engaging multiple sectors, from prescribers of controlled substances to treatment providers to law enforcement or other sectors of the economy?
So, as part of the governor's State of the State address, he announced that by this fall, we'll be working to address a new strategy around prescription drug and opioid abuse in particular. I think we've seen the number of accidental deaths quadruple.
Yep.
I think that's about right, over the course of the past decade. So this is an issue that's becoming much more prevalent, and it's not just a Michigan issue. I mean, a lot of states are really struggling with a strategy around this, and it needs to be a comprehensive one. It's around treatment, it's around law enforcement, it's around our regulatory structures. Data is a key thing in this. So I mean, we are, first, we are going to be working towards a new strategy around this issue. But then further, you get the other mechanisms that we've been leveraging, whether it's Healthy Michigan, whether it's you know, the mental health system and substance abuse treatment through that system. Yep. I think that you're seeing a lot of new resources that have been able to go there to help people who need treatment when they need it. So I think that's overall been a net positive, and quite frankly, Healthy Michigan's been a key driver of that. But you know, I think there's still a lot more to do, which is why we've kind of laid this out as a priority for us over the next year. So this is going to be an ongoing effort that we go through. But the idea is to have a new strategy for the state.
I think it's
in place by late fall.
Yeah, I think it's a couple areas, you know, within the strategy itself, but a couple of areas that we need to focus on. And this is really sort of interesting, you know, societal reaction to this, because we started hearing about these high-profile deaths related to prescription drugs, and we certainly see that across the country. And we talk about increased regulation, but with the increased regulation, the increased scheduling, we've made these drugs harder to attain. They're more expensive, and we've seen heroin use skyrocket because of it. So heroin deaths have really increased over the past decade as well. And I think the other piece for me that we have to get after, it's about the data around prescribers. You know, there's a lot of resistance to using some of the prescription drug databases in the past for, you know, I'm going to call it data mining, but data analytics would really, you know, either one, help us improve care, or two, help us root out fraud or unsafe practices. And that's something we're going to look at. Yeah. You know, what can we use data-wise that would push us towards identifying either the prescribers who are fraudulent, or creating a situation that results in dependency, which I think should result in delicensure and prosecution, plain and simple. And is there also just, you know, can we help improve the practice, right? Where maybe there's other options besides these drugs. And it's also interesting because we've gone from an environment where pain management was very important 8-10 years ago to now, you know, it seems like the pendulum has swung the other way, and there's an overprescription problem. So, yeah, the governor
It's starting to swing. I mean,
the governor charged one director to do this by the fall, and you can guess who it is. So that's something we'll be putting together for the fall.
Okay.